Yes, Mrs. O, a 59-year-old from Andhra Pradesh, presented with complaints of behavioral changes in past 15 days and not verbalizing for the past 3 days and decreased food intake for the past 3 days. She was apparently normal 15 days back when she developed personality and behavioral changes characterized by social withdrawal, apathy, and lack of self care. She's a landlord and she lives alone since her husband passed away 9 months back. And she used to take care of her lands and usually goes to the farm, but and usually cooks for herself as well. And recently she stopped cooking for herself. She stopped going to work, and then she felt unwell, so she went to her brother's house. There, initially she was interacting with them well, and gradually she stopped. The interaction came down, and usually speaks with her son on the phone as well, and the number of interactions came down, and she later only responds when they were prompting her. Otherwise, she was completely silent, and she also required assistance for usual activities of daily living, and she didn't eat unless prompted frequently. And in the lack of self care also was also there. She did not take bath in the last 3 days. So in the past 3 days, she was completely bedbound and did not speak to anyone at all. And she had to be fed in the past 3 days before presentation here. And yeah, this was a picture. Then she has complaints also decreased movements in her left upper and lower limbs as well. There was one history of one fall and head injury 20 days back when she was living alone. There was no loss of consciousness, no seizures or vomiting, and she went to an outside hospital there and did the MRI, which showed a chronic infarct in the posterior temporal lobe left side, and they were treating her for depression there for the same. Then past history wise, no known comorbidities. She's postmenopausal, and personal history. She's a vegetarian, and normal bowel and bladder habits are there. She has disturbed sleep. She wasn't sleeping properly also in the past 10 days, and she has reduced appetite. On examination here, she was conscious but mute, and vitally she was stable, and general examination was normal. On CNS examination, she was drowsy, but response to pain, spontaneous eye opening was present, but she did not verbalize or respond to any of the commands. Occasionally, she was responding, when we asked to lift her hand. Very rarely she used to do, but otherwise she wasn't responding to her surroundings as well. Memory could not be assessed. Emotions, she was apathic, and speech, some incomprehensible sounds were heard. She could able to make. And cranial nerve-wise, so people were bilaterally reactive to light and accommodation. And third, fourth, sixth cranial nerve, extraocular movements were normal. And fifth nerve, corneal and conjunctival reflex were intact. There was no deviation of angle of mouth or nasolabial fold was intact. And gag reflex was present, and there was no deviation of deviation of tongue. But tone-wise, she was hypertonic throughout in both upper limbs and lower limbs. Power could not be assessed, but she was moving all four limbs normally. Reflexes wise, knee jerk was slightly exaggerated, otherwise normal deep and reflex everywhere. Plantars were flexor, and rest no, she wasn't cooperative for sensory system examination. So the differential we initially considered were encephalopathy or encephalitis, possibly due to initial viral tuberculosis, spirochetal infection, vasculitis, and autoimmune causes we are considering, and metabolic wise dyselectrolytemia and uremia, chronic liver disease, and psychiatric causes schizophrenia, bipolar disorder, and unipolar major depression were the differential considered. So initial investigation wise, her hemoglobin was 12.8 with total counts of 8,600 with neutrophilic predominance, and platelet count was also in the normal range. Sodium, potassium, and calcium were, no, except for slightly, she was hyperkalemic, and phosphorus were 4.9, magnesium 2.23. Urea creatinine also normal, 26 and 0.68. LFT parameters were normal except for slightly elevated alkaline phosphatase of 142. We done ANA and ANCA, which was negative, and EEG showed bihemispheric slow wave disturbances. And CSF studies, we did a lumbar puncture, and there was no pleocytosis The glucose and protein levels were in the normal range. The bacterial culture was negative, and the AFB smear, MG expert, everything were negative. We sent a CSF multiplex PCR also, which was negative. So, imaging wise, the CT brain showed age-related changes and gliosis in the left temporal lobe, and the MRI brain was consistent with the previous MRI done outside, which showed a chronic infarct in the left posterior temporal lobe. So, this was the picture. And then on clinical examination, on day we found to have this is not her video, it was another one similar video we managed to find online, and she had this feature. So any differentials as for any other possible causes this based on the history investigations on this feature. So we had an extra sample of CSF left and we sent it for an autoimmune encephalitis panel, and it came 2+ NMDR positive for her. So anti-NMDR encephalitis, it is usually secondary to viral encephalitis, or it could be paraneoplastic. And it is a cell surface receptor. NMDA is a cell surface receptor, and the antibodies act on it, and it causes cross-linking and internalization, causing reduced NMDR density in the brain that causes these clinical features. So yeah, NMDR encephalitis predominantly has psychiatric manifestations, presenting as anxiety, agitation, bizarre behavior, hallucinations, delusions, and psychosis. Sleep disorders include sleep reduction at the disease onset and hypersomnia during recovery. There are memory deficits, seizures could be possible, catatonia. Our patient was also was like that, and dyskinesias, orofacial, chorioathetoid movements, dystonia, rigidity, opistotonic posture could be possible, and autonomic dysfunction could be there, and language dysfunction with diminished language output, mutism, and echolalia are seen in anti-NMDR encephalitis. So there's a study done in 2017 which shows red flag signs for identifying autoimmune encephalitis in psychiatric patients, because most of these patients end up in psychiatric department for this clinical presentation. So how to identify them and early diagnosis and treatment, for that they have made a criteria. So the psychiatric abnormalities were the presenting signs in 60% of the patients. They were doing a retrospective cohort study based on the patients there, and 1/3 of patients were initially hospitalized in a psychiatric ward. All patients positive for antibodies against NMDA showed behavioral changes, hallucinations, memory deficits, catatonia, or delusions. The time between the occurrence of the first symptoms and the antibody testing and eventual diagnosis was alarmingly prolonged. So in the years 2007 to 2012, it was 483 days between the average time was 483 days between the symptom onset and the diagnosis, and it became better in the 2013 to 16. The mean delay was 74 days. So what features could we can consider in a patient presenting with psychosis or psychiatric symptoms towards an organic cause like this? So these features are consistent in patients with autoimmune encephalitis. So yellow flag signs could help us to keep autoimmune encephalitis as a differential in a higher level, and red flag signs should definitely mean we should pursue an antibody testing. So our patient had abnormal postures and movements, orofacial limb dyskinesia. There are other features here, focal neurology disease, that history of left upper limb and lower limb weakness was there, and she had aphasia, and here catatonia is there. So other features, decreased levels of consciousness, autonomic instability, rapid progression of psychosis despite antipsychotic therapy, headache, and associated with association of other autoimmune diseases. So these are the yellow flag signs. And red flag signs, we have EEG abnormality, slow wave abnormality in the bihemispheric areas, and other things is CSF pleocytosis and MRI abnormalities, fatiobrachial dystonic seizures, suspected malignant neuroleptic syndrome, epileptic seizures. These are red flag signs. which means that we should definitely do an antibody testing. And this cohort study, they applied this criteria. After applying this criteria, there is a reduction of 58% in the time delay in diagnosis. Initially, there are 74 days, but when applying this criteria and triaging the patients, reduce the time for diagnosis to 31 days. And in the NMDR group, actually it went from 40 to 10 days. And non-NMDR encephalitis patients, those are 150 to 52 days, but there is a significant improvement. So management wise, early detection and management yields a good prognosis in autoimmune encephalitis. Usually that's also in HSV encephalitis, that occurs secondary to viral encephalitis. So the pulsed IV methylprednisolone therapy can be given. It can be combined along with an IVIG and therapeutic plasma exchange. Second line therapy, rituximab and cyclophosphamide can be considered. And if usually this anti-NMDR encephalitis associated with tumors, like in young age group, ovarian teratoma is a possibility. So early resection of the tumor is also associated with good prognosis of the patient. So our patient, we did a PET CT to look for any possible source of the tumor. She was started initially on IV methylprednisolone pulse, and side by side we did a workup for malignancy as well. Unfortunately, we found a mass in the middle lobe of right lung and significant mediastinal lymphadenopathy, and there are multiple sclerotic bone lesions in thoracic and lumbar vertebral bodies. So overall, primary lung malignancy with metastasis diagnosis was made, and the paraneoplastic encephalitis and NMDR that occurs due to this malignancies has very poor prognosis because it is unresectable also. And we gave IV methylprednisolone for 5 days. We did not have any improvement, and the patient side wanted to shift her to her hometown for comfort care, and she was discharged against medical advice. So learning points, the clinical features of anti-NMDR encephalitis, the usage of warning signs to facilitate timely diagnosis and early treatment initiation, because there is a need for early diagnosis, because treatment delay of just more than 4 weeks since symptom onset is associated with poor functional outcomes. So we need, we can use this criteria for early triaging. Thank you.
What's the pathogenesis? How did the tumor cause the NMDR encephalitis?
Yes, sir. The tumor, the antigens, tumor antigens, our body produces antibodies against it. It is predominantly intrathecal production of the antibodies. So usually CSF testing is must be done. Serum antibody testing might not yield a result, but CSF testing will almost always be positive at the time of presentation. Because the plasma cells are predominantly located in the intrathecal space.
So what's the, how specific and sensitive is the CSF NMDA test?
CSF usually at the time of presentation, there is a autoimmune encephalitis, almost 100% specificity is there in CSF testing.
What's
We need here also the patient group was 100 only. We need further with a higher.
You mean the red flag, yellow flag sign?
Yes.
In that study, you're saying it's 100.
It's 100. It's a population of 100. We need furthermore systematic reviews of case.
Okay.
For
all right. Any questions from the audience? Ask something. It's a novel area, I think. You might have some burning questions. Okay, let's make it mandatory for the first years to ask something. Are there some first years? Go ahead, ask something if you have any questions.
Will you get any C-spine imaging?
We didn't do a suspend.
These are limb hypertonia, cyclic gyral reflexes.
Yes, sir.
Will be an encephalomyelitis syndrome. I think lung malignancies are more associated with encephalomyelitis like COVID and was there an onco-neural panel for?
Yeah, we didn't do an onco-neural panel after the initial
PET scans report.
No, so after PET scan only, she actually got worsened after the. She didn't respond to the 5-day methylprednisolone therapy, and the patient wanted discharge, and we couldn't further. We planned for a biopsy of that lung malignancy as well to characterize, but it didn't go through.
And is there a difference in if you have a paraneoplastic lung malignancy? Is it generally small cell carcinoma, or is it common with adenocarcinoma?
Usually, small cell lung carcinoma is associated with paraneoplastic.
Is there a chance that the NMDA could be false positive and may have been an onco-neural antibody?
Yeah, it's something to look for.
The patient came with the UMN syndrome of 4 legs and encephalopathy along with the.
Usually, that hypertonia is possible with the anti-NMDR and encephalitis. This is a known feature also.
So, one question that would arise is how did they come to the conclusion that NMDA has 100% specificity? What was the diagnostic test that was used to confirm that NMDA receptor has 100% specificity?
And there is an anti.
Did they use some sort of clinical criteria or brain biopsy, whatever? That's the thing I was interested in. Okay, that's something to look into.
We'll look into it.
Okay, so thank you. We'll move on to the next presentation.
Thanks.